I'm going to take this a little bit differently. We're going to talk about a professional education strategy and a newer classification system that we might be surprised didn't exist until 2 years ago. So I think I want you guys to ponder something as I go over what the learning objectives that we're going to do tonight. I want you to think about this. How do you establish your return to play protocol for a lower body injury today, right now? How would you do that? Because as I'm going to ask you guys to share a few things that you personally would do for any lower extremity joint return to play that they could go back. Okay. But tonight's learning objectives, our participants will analyze their current practice for lower body return to participation tactics. Our participants will go ahead and reflect on the PASS, which I'm going to call PASS, items that they use in their current practice and what they don't necessarily use in their current practice as of right now. And our third learning objective tonight will be that the participants will consider the importance of participating in a professional-based research project on the PASS framework. Okay. Not leading you into anything, but I want you to think about that. That's our learning objectives tonight. So I'd asked a question just a moment ago. How do you establish your return to play protocol? So everybody just at least give me one thing. You get a minute to talk at the most. So who would like to go ahead and unmute themselves and share?
I'll go first.
Oh, thanks, Warren. I appreciate that, my friend.
I got you. So for lower extremity return to play.
Yes.
Yeah.
Yes.
Usually we will have them complete. It depends on the injury. So like if they have a stress fracture, they're gonna do a progression on our Alter G, and then they're gonna do progression on the treadmill, and then they're gonna go back to practice and progress through practice. And that's after they've gone through rehab, no pain, cleared by the doctor, all of that fun stuff. But then we'd use clinician rated outcomes, the treadmill progression, stuff like that to identify whether they're good to return to sport. And then when they do return, their coaches have their own progression for them as well. So they're not just thrown back like into full load.
Awesome. Okay. Exercise related. Haven, you look like you were raising your hand. You ready to give me one thing?
I was just repositioning myself. I'll get some input. So when it comes to return to play, a big thing for me is comparing bilaterally. I like to, whenever I can, always compare when it comes to progression. And then from there, I'm still starting to implement like a PRO on this topic, but patient confidence in their abilities and how comfortable they feel with whatever associated joint or lower extremity injury that they've had. And then lots of functional exercises. I like to have my patient feel comfortable with plyometric exercises more than anything. That's kind of what I've kind of developed as like my benchmark on identifying when they're, feeling confident and ready. Once I get to that point where, the patient is executing these functional plyometric exercises or drills effectively and properly with proper biomechanics. And then the patient reports back to me saying like, yeah, I feel comfortable, it feels good. And then the next day we'll see how they're feeling. And if they're still feeling good, then I feel confident in their abilities to start their return to play progression.
Excellent. Excellent. Adam or Kaylin?
So I use what the orthopedic group near us just gave us. They gave us a functional progression. Forte just gave us one. So that's what we use.
Okay, so far I've heard functional, activity. A little bit of patient buy-in that they feel good. Adam, what do you use?
I have nothing. Like it depends on the injury. We're talking like there's a big difference between, hey, I sprained my ankle a little bit during practice versus ACL, right? I think ACL, I would follow the protocol. But if it's like ankle sprain, maybe tomorrow let's do like, no jumps. I'm working with volleyball, probably no jumps tomorrow.
Right.
Then let's do some on the ground drills. And maybe the day after, let's jump a little bit, like do 50%, or because in season, out of season also makes a big difference, right? You gotta play at the weekend, right? I mean, right? So right now for that kind of injuries, I don't have like a fixed protocol because I mean shit, I mean it's very complicated when you're in season and you have to play, and then there's like also sports, right? We're not
Right.
running, we're doing like
Right.
complicated activities, right?
I'm so glad you shared last, because that leads me right into the rest of this lesson. Thank you. That was even unscripted. You are perfect, Adam. Okay. So this is all about managing lateral ankle injuries. And we're really talking about that acute setting, just like you started to talk about. And shockingly, until 2021, guys, there weren't any guidelines for return to participation for lateral ankle injuries. And that's one of the most common injuries we have. So this framework that's kind of in the central part here, and I'm going to go ahead and I'll get you guys kind of down to one, and I'll move Adam over here so we can see this a little bit better. The central part is what the pass is. That framework that was devised. Let me speak for a moment about that. This framework came about because there really aren't guidelines yet currently for this return to play. And why is it important? Well, 3/4 of the people in the United States who are secondary ed athletes, so my population, they will have an acute lateral ankle sprain, and within 3 days they're back out there. Now, we all know histologically the ligament is not reorganized itself yet. There's a lot of problems, and even when we go with that acute injury, 95% of them are back within 10 days. That's hard stats that these people were using to validate why this is an important step that they needed to take. So we're bringing people back pretty quickly, and that premature return to participation may be one of the leading factors to our chronic ankle instability and all the issues that go along with that very high prevalence. So ultimately, this end product we have that's kind of in the center is 16 of 35 items that were chosen by panelists from an international group of professionals as to being the bellwether, or this is what we really need to make sure that these people can do before we let them go back. Now, click through. There we go. Okay. So they used 155 people, and I thought it was interesting that they took individuals from major sports programs. So you're thinking elite level professionals. They were coaches, they were medical staff of varying levels, they were clinical physiologists. But these people were kind of handpicked. So I thought that was a little interesting. They were looking for the best of the best to answer from these experts. It was not a random, every orthopedic surgeon or every athletic trainer. It wasn't like that. It was very specifically specifically selected group of people were chosen to participate, and most did. They had like an 80% return on the first round of their research. So ultimately what they were looking at, they had this list of items that they thought were valuable for a return to play decision, and they ranked them. And if you had consensus, meaning you ended up staying on the list or you were removed from the list, it had to be 70% of the panelists. So it was either a for or against, you got to stay or you were immediately removed. And if you didn't get 70% either direction, You stayed on for the next cycle, as the case might be. And they eventually again distilled it down to 16 from the 35. So they came up, this group, with these 5 domains. In everything that you guys mentioned just a second ago is here. You did a phenomenal job leading us to this. So this isn't a novel idea, but distilling it into this creation developed product is unique. It's not been done before, but we're all doing most of this, or at least parts of it. And here we've got a checklist. I equate this to almost having a SCAT system for us to manage concussions. We were hodgepodging a lot of things, but now, you have a very systematic way to do things. That's what this becomes. So the acronym PASS came from these 5 domains that were created. And let's take a little deeper dive on those. So P, pain, that was during sports participation or over a 24-hour period. I think ultimately what they were looking at was, do you have pain after you've had a practice for the next day, was what they were really looking at. Did you have discomfort, and then it stayed with you. The first A was, hey, exactly what you guys said. I compare body parts. We look at range of motion. We look at muscle strength. We look at endurance measures. Whether it is, hey, I could run 2 miles with no problem, and now I can get to maybe 3/4 of a mile, and my ankle starts to hurt, and I just don't feel good. Okay, well, they don't have their endurance. Power, so we're dealing with all of those jump kinds of things, the explosiveness, the plyos, all that stuff right there. So pain, ankle impairments. The other A is the athlete perception, and they hint about the psychosocial readiness. But one thing, and I'm just going to go ahead and put this little tickle out here about things that get left off. They don't ask how the patient really feels directly. They don't directly do that, which is a little disconcerting, but they didn't feel that was important, I suppose. We'll talk about that in a minute. The perceived confidence, do you feel safe, secure? Does it feel stable? Those are athlete driven comments, but we have to drive them through the questionnaire or the process of obtaining that information. So getting a little bit more into, again, the clinician objective, something that we're actually measuring, the idea of proprioception, the postural controls, balance, trying to get them off balance. How safe are they going to be going back in an environment that is not always stable? So I think some of us miss that, but a lot of us do the proprioception. We just won't do the postural control things. So that's a little unusual here, perhaps, especially if we're just trying to get somebody back the next day. The last S, again, we do this stuff. You guys identified it right at the beginning. Again, jumping, the hopping, agility drills, maybe even a T agility, speed test, something like that. Very sport specific things. And then can they get through a full training session? Now, I'm a big proponent of that. I'm not if it's not in the heat of the moment, they've got to go through practice before they can play. I mean, that eliminates some stragglers, certainly. We're going from there. I'll make sure we've got everything up. That was Warren. I apologize. I always make sure when I'm doing a session that if I see a chat, we answer it, because something could be going awry with someone or with the program. So what is missing that we would have expected to see there? What you guys mentioned earlier almost mimics everything that they thought was most important. But after being in the DAT for the last 5 months, I think, 4 months, 5 months, there were some things that I expected to think is important information that was not there. Does anyone at this point, having looked at those 16 items, was there anything there that you were like, why isn't that there? You could just unmute, shout it out, or throw it in the chat.
I would say patient-rated outcome measures.
Amen. I totally agree with that. Does anyone else think, like, why isn't that there?
Well, perceived, what was it? Perceived something
Hang
was
on.
that.
Let me go back. Oh,
Yeah.
crap. It's not gonna let me go back. Hang on a second.
There was something about perceived patient something. Is that what
Yeah.
you're talking about, Warren?
So yeah, and so it might not say like specifically PROs, but I feel like PROs would fall under that category.
Give me 1 second. We're gonna get to it.
Yeah.
So you would think, but it didn't say it. And one thing that, we would infer it to mean that, but they did not specifically. And I'll show you what they said here.
Okay.
Apologize for that. So they did not believe that, I'm gonna get this out of the way here. Get your heads out of the way, maybe not. They did not believe that a functional movement screen, the STAR excursion, the patient-reported FAM or FAOS, that they were significantly sensitive or sufficiently sensitive, either of those, to be included in a return to play. And I was like, okay. But they also did include some other things that you might think about, because remember, this is acute, and in an acute injury, they're talking here, with what they thought was important was the pain, the impairments. There's one thing that's not here. If you had somebody that had a very swollen ankle, did they get an x-ray? No. They said that was not a valuable tool for a return to play. The table that they have, and I just want to read a few things. I didn't put it in here because it was a little cluttered, but things that they left off that we would have assumed was already happening. Structural integrity on imaging of the ligaments. We're not going to get an MRI on our people right away, but if you're getting paid $10 million to play, 20 soccer games a year, yeah, you're going to get that to happen. A week-long look at the severity before. Does it hurt or increase pain when you palpate? Health-related quality of life. Yeah, they did not think that was important.
What?
Yes,
What
that was left. That was left off, and they didn't say that you could only have 16. They could have agreed on all of them. I'm like, what? I thought that was a little unusual, but I'll give you some reasoning why I thought that might have happened. Other leg or kinetic chain, how's the knee, how's the hip, arthrokinetics, reaction times, lower limb or trunk kinematics, straight line running speed, foot biomechanics, none of that stuff. And kind of my pre-screen go to the functional movement screen, not important. I was a little surprised. Now, why do I think that was their frame of reference? Well, interesting that we have most of our men here in our cohort. They're with us tonight, which is wonderful. But I think the biggest thing about the participants were their average age was almost 42 years old. So that meant you had people who were a lot older in this. And we were trained that didn't matter. It was all very objective measurements that we would incorporate. We did not do patient-centered care. And that's the one thing is eloquent as this is about condensing and giving us a nice clean script to follow to get somebody back in an acute lateral ankle sprain situation. We forgot the patient. They hint about it, but they don't dive into it because I just don't think that they were trained to think that it was important. So that was a little challenging and painful to see that actually happen. So I guess my take home of this is a few things. First of all, when we're looking at the new and improved things, again, I was excited about this, guys. It was cool. We finally have a way to actually dive in and quantify something quickly. Here it is. It's something that can be put on a 5x6 card or 4x6 card and put in a kit, and you immediately pull it out. So the coach is like, well, can they go back? And you got it right here, and you can say check, check, X, 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 X. This is why they can't. So kind of a protective measurement for us. But the reality is it missed some very important things. So we have to always be willing to really take a look at things and analyze them before we go at it. And just incorporate something. The other thing that struck me as funny is that, of course, you have physiotherapists, you have physical therapists, you had these orthopedic surgeons, you had sports medicine physicians. They did not identify specifically athletic trainers that were trained through the board of certification process. And Katie, they didn't identify those people that way, who we are, and I would wonder how our past framework would either compare or contrast to what other healthcare professionals are thinking. So that's just kind of a food for thought. So putting that in your mindset about not only evaluating this specific issue, but when we incorporate so many other pieces to our world that we use every day that came from other healthcare systems, we need to start supporting and incorporating our own ideas, because we do have a very unique framework, and that's what I would hope that we would be able to accomplish. Now, does anyone have any questions? I'm gonna try to get our video back here. I've got my participant list, but if I start mine, let's see if it'll trick it to coming back, and it's being fussy tonight. Anyone have anything at all? You want to shout it out or throw it in the chat? Okay, stone silence. That's okay. All right. Your assessment is in the email to your Indian State account, and if you would please take a moment to go ahead and that little blip finally came up for me. Go ahead, access that within the next 24 hours, complete it. Take a little time to reflect about some things. I'm so thankful that you guys supported so much of that before we even dove in. But then our opinion and what we value with the people we deal with every day was maybe not addressed. So, but I'll leave that up to you. Thank you for your time tonight, and be safe going home.